Good afternoon, a happy new year to you and welcome to a new term of Eurotransmed. Today our subject is cholesterol management and the weight of evidence. And we're very pleased to welcome as moderator Dr. Bill Roberts from the National Institute of Health in Bethesda, Maryland, USA. Before I ask Bill Roberts to introduce his colleagues today, let me remind you that the success of Eurotransmed is its interactive formula. This is as much a conference as a presentation, or in other words, we like to hear from you, preferably by phone, but also by fax if you prefer. Here are our numbers. We'll remind you of them later in the programme, but if you want to make a note of them now, our phone number is 44 for the UK, 81763 9080. That's the same number as last time. But we have a new fax number today. In case you've got a note to the old one, this is the new one, 44 for the UK, 71261 3805. I know some sites like to collate their questions, so we'll take a short break midway through the programme. But now let me hand over to Bill Roberts. Bill.
Thank you, David. It's a pleasure to be here. There are four of us on this panel. To my left is Professor Giorgio Ferulio, who is Professor of Cardiology at the Regional Hospital Udine, Italy. On my right is Dr. Tony Keach, Coordinator of the Oxford Clinical Trials Unit, and to his right is Dr. Gilbert Thompson, Consultant Physician in charge of the Lipid Clinic at Hammersmith Hospital in London. I thought we would start this by discussing the atherosclerotic risk factors which are listed here. In my view, there is only one direct, unequivocal atherosclerotic risk factor, and that is an elevated total and specifically an elevated LDL cholesterol level. Now, there is a debate as to what elevated means, but if one wants to prevent the development of atherosclerotic plaques sufficient enough to cause ischemia of a body organ, that total cholesterol has to be under 150 milligrams per deciliter, which is 3.9 millimoles per liter. As the level goes up after that, the risk of an atherosclerotic event goes up in more or less the same magnitude. Now, these other factors listed here, male sex, history of either myocardial infarction or sudden death in a family member before age 55 years, cigarette smoking, systemic hypertension, HDL cholesterol less than 35 milligrams per deciliter, 0.9 millimoles per liter, diabetes mellitus, definite clinical evidence of coronary artery disease, cerebrovascular or peripheral vascular disease, and severe obesity, in my view, are indirect atherosclerotic risk factors. Now, what do I mean by indirect? What I mean by that, if a person has a total cholesterol level, for example, of 3 millimoles per liter, 120 milligrams per deciliter, it doesn't matter how high the blood pressure is or how many cigarettes that person smokes a day, that individual will not develop atherosclerosis of any significant degree. After total cholesterol is greater than 150, on the other hand, these other factors are accelerators of atherosclerosis, but in and of themselves, they are not direct atherosclerotic risk factors. Next slide. Now, listed here are the factors linking cholesterol to atherosclerotic plaques. The connection between cholesterol and atherosclerosis started in the early part of this century by some Russian physiologists who fed high cholesterol diets to certain non-human animals, namely rabbits, herbivores. One cannot produce atherosclerosis in a carnivore. And they produced atherosclerotic plaques similar to those occurring in humans. The next thing that happened, the biochemist came into play and found cholesterol in both experimentally induced atherosclerotic plaques in these rabbits and in plaques in human beings. The third thing that happened, the international epidemiologists came into play and studied groups of people in various countries around the world. I conclude from those international epidemiologic studies this third statement. Atherosclerotic plaques large enough to produce clinical problems occur only in persons having serum or plasma total cholesterol levels greater than 150 milligrams per deciliter. These three items here, 4, 5, and 6, were confirmed primarily in the last decade. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Number 5 came about in 1984, was confirmed essentially in 1987, lowering the blood total cholesterol level, and specifically the LDL cholesterol level, decreases the chances of fatal and non-fatal atherosclerotic disease. Item 6, atherosclerotic plaques regress when high blood cholesterol levels are lowered. Now, most of the secondary prevention trials, which we will hear today, were published in 1990. So the regression concept is relatively new. So in my view, these 6 factors here show beyond any reasonable doubt that atherosclerotic plaques are linked to cholesterol. Thank you. Comments, gentlemen?
Bill, you stressed, I think quite rightly, the importance of LDL cholesterol as an atherogenic risk factor, and you listed some of the others, but I think it's true to say that HDL cholesterol might also be considered a risk factor in its own right, in that you do have, relatively rarely I agree, but you do have situations where patients with a perfectly normal LDL do have premature atherosclerosis if they have a very low HDL.
Right. Well, I agree with you, Gil. There's no question that HDL is important. The evidence for that is accumulating each year. Recently, we published in the journal that I'm involved with two papers. Both were angiographic studies in individuals with coronary disease, so that they had angiographically confirmed coronary narrowing. And half of the individuals in both studies had total cholesterol levels less than 200. And the major reason those levels were less than 200 was because the HDL levels were quite low. So I would agree that HDL is important. The evidence, in my view, is not as strong, of course, as LDL, but it's certainly important. We had a patient that Dr. Fredrickson studied for many years who had a total cholesterol of 72 and had a coronary bypass operation. But his HDL cholesterol was only 1.
Dr. Roberts, some more evidence is accumulating about triglycerides today as a risk factor. As a matter of fact, in one supplement of your journal, the American Journal of Cardiology, has been dedicated to this problem, which is emerging. And triglycerides apparently have received more attention when the HDL is low or when the ratio LDL-HDL is above 5.
Right.
Can you stress this point?
Yeah, I think the conclusion of triglyceride is still not in, the importance of it. There's no question that as the triglyceride level goes up, the HDL level tends to go down. So maybe one of the dangers of the relatively high triglyceride level is the fact that the HDL level is down. So that might be how it's working. Of course, the very high triglyceride levels produce the pancreatitis, and they're obviously quite dangerous. I think we better go on to you, Giorgio. The title of your presentation is Primary and Secondary Prevention Trials.
In the last 30 years, many control trials have been carried out for primary and secondary prevention of coronary artery disease by lowering cholesterol levels. For today's debate, only a few will be considered among those trials more significant and better known in the medical literature. Here, this slide presented some of these trials on primary prevention based mainly on diet. And as you can see, are not very recent ones. The first two belong to the years of 60. And all of them, the presentation just to follow the numbers on the screen is here given in this way, that you have the last three colors in color is a relative reduction in total cholesterol, in orange. In yellow, the relative reduction of coronary events. And finally, in green, the last column to the right, is a relative reduction in total mortality. Well, here, as you can see from these primary prevention trials based on diet, low cholesterol diet, and low saturated fat diet, there is, after a period of 5 to 8 years, a significant reduction in cholesterol, in total cholesterol, from 12 to 15%. And if we come to reduction of events, of coronary events, only in 3 of these trials we have some significant results, and the last one in the bottom had no results at all. The same in this last trial, Minnesota Coronary Surveys, also we didn't get any significant reduction in total mortality. Instead, we had a plus 3% of total mortality. If we come to the trials of primary prevention based on drugs, then here again I report 4 well-known trials. 2 of them are extremely stimulating in considering the whole problem of cholesterol and lowering and coronary artery disease. Anyhow, the drugs here used are clofibrate, cholestyramine, and gemfibrozil. And again here, the column in red, in orange, you can see there is a significant reduction in relative reduction in cholesterol from 9 to around 9–10%. And also in 3 out of 4 these trials, there is a significant reduction also in coronary artery disease. Just 1 had no significant changes in incidence of coronary events. And coming to total mortality, we had only 2, the central ones, showing a significant reduction also in total mortality, 4 and 25%. But there are other 2 that I stress this fact, they have an increased total mortality. Well known the data in WHO clofibrate, a very interesting study concluded in 1978. Coming to secondary prevention trials, here we present some of the trials based mainly on diet. And again, there are some not too recent ones. The one of Rose of the Medical Research Council. All of them had, they have lasted from 2 to 5 years. The last one, the Singh trial, the trial by Singh is not to be here discussed. But we have the first 5 trials, all had a significant or favorable changes in total cholesterol. But only 1 had a significant reduction in coronary events. And if we come to total mortality, we have 3 of them that had significant reduction in total mortality, no significant reduction in the first one, and in the Woodhill diet trial, we had a 42% relative increase in total mortality. if we come to the next trials that concern the secondary prevention based on drugs, here we present again 5 trials, 4 with drugs, and the last one is a surgical trial, the POSH one with the ileal bypass. But let's consider the first 4, which lasted from 5 to 6 years. And here again, we have a good response in cholesterol reduction and also a good response in relative coronary artery events reduction, with really 2 data, the first and the 4th one, really significant. And also we had a total mortality reduction, which reached significance in 2 of the trials. Well, we have to conclude this review by also introducing in the realm of trials for secondary prevention, the angiographic evidence of trials which lasted from 2 years or more than that to 10 years by reducing cholesterol, either by combining diet with hypocholesterolemic drugs such as clofazimine, niacin, cholestyramine, cholestyramine, and lovastatin, or using only drugs. Well, if we come to, unfortunately, these studies here are all controlled studies by angiocardiography, by coronary angiography, and altogether they bring up nearly 1,000 subjects, are small numbers, but in all we observe a relative reduction in cholesterol levels, the orange column. We had in 4 out of 7, in 5 out of 7, we had also a significant reduction in progression of the coronary lesions, and in 3 of them we had also a reduction in significant signs of regression of the plaque. So I will conclude this quick survey of these trials by stating that there is agreement about the fact that both diet and drugs are efficient in reducing both cholesterol levels and coronary events. For every 1% reduction in cholesterol, there will be from 2 to 2.5% reduction in coronary artery disease incidence. Drug trials appear to be more efficient than diet, although there are trials with different design. Efficiency higher in secondary trials is reported. And there is, however, no agreement as yet on total mortality. Thank you.
Thank you very much, Professor Ferulio. Let me ask you a question, if I might, Giorgio. Diet is many things. In the USA, the average American adult takes in 40% of their calories, more or less, from fat. Now, if you knock that down to 30%, it's my understanding you can, in most people, diminish cholesterol on average of 8 or 9%. Now, if you had a total reduction of total cholesterol by a drug of 8 or 9%, you would think it was not very effective. My question is really this. It's my understanding that if you knock somebody's percent of calories from 40 to 30%, there will be some individuals in there that will have no effect at all on their total cholesterol levels. And then there will be others that have a very dramatic effect. But in these group studies, you're lumping them all together. How do you handle that? I mean, if we could all get our total calories down from fat to 20%, more or less like the Japanese are today, I mean, our health would skyrocket. What do you recommend to your patients regarding diet?
Well, regarding diet, I mean, there are several standardized diets. I recommend, of course, to keep the percentage of calorie intake as a fat less than 30% altogether. Second point is to keep, as the recommendations from many agencies today are accepted, to keep the total cholesterol per day certainly less than 300 milligrams per day. And then to introduce also in the diet fibers and more carbohydrates complex, and to move towards what I mean is a balanced diet with low level of saturated fat. And of course, it will depend upon the population, but in the population you have several groups of people in which diet is not effective and is not always well accepted, especially in the female groups, where of course also coronary artery disease today appears more and more often as a data. I would like to also hear the other components of the panel, what they mean.
I think that the effects of diet on cholesterol are very variable, as Bill said, but that if you only get a very small reduction in cholesterol, that doesn't necessarily mean that the diet is going to be ineffective in terms of prevention of coronary disease. I think there's quite good evidence to suggest that the effect of diet, particularly the PS ratio changes induced in various tissues like adipose tissue, can be shown to correlate independently with coronary disease. And it may well be that one of the major effects of diet is to beneficially influence platelet function and thereby render blood less coagulable. So that could be a sort of spin-off from a diet. Maybe I could also just ask you one question about secondary prevention. I think your data suggested that the strength of the secondary prevention trials, particularly those using drugs, was rather greater than the primary prevention. And I think this is very important. I think Tony Keach would probably agree that the epidemiological data suggests that hypercholesterolemia is an even more important risk factor for reinfarction in somebody with pre-existing coronary disease than it is for a first infarction in somebody without it. Yes. And I think it's terribly important for cardiologists to realize this and to treat even relatively mild hyperlipidemia in patients with pre-existing coronary disease.
Yes.
Would you say, Gil, that in somebody who's had an atherosclerotic event, in other words, secondary prevention, do you think it's proper in those individuals not to focus so much on the cholesterol levels, but just to get them lower? Because no matter what the level is in somebody who's had an atherosclerotic event, it's too high for that particular individual.
No, I think I would agree with you. I mean, my threshold for treating somebody who's already got coronary disease is much lower than my threshold for starting treatment in somebody who might or might not get it in the future.
Well, let me pursue that. Do you think that everyone who has had, let's say, an acute myocardial infarction and they survive should be on a lipid-lowering drug, one or more, in addition to a low-fat, low-cholesterol diet?
I don't know that I would go as far as that, but I would say that if you can't get their cholesterol level below, say, about 5.2 millimoles per liter by dietary means, then I think one should seriously consider putting them onto a drug which will achieve that outcome.
So in somebody who's had an atherosclerotic event, you go for under 5.2?
Yes.
What about you, Tony?
Well, I think we don't actually know yet how important that is. My belief, as yours and Gil's, I think, is that it will be important to lower cholesterol in a patient who's had a heart attack, irrespective, perhaps, of the starting level of cholesterol. But I think we do need to gather the necessary data to determine that that is, in fact, the case, which would indicate that we should be treating patients with perhaps with cholesterol-lowering diet and possibly drugs after myocardial infarction routinely. So I would await further trial evidence, I think, like perhaps Gil would, before attacking levels of cholesterol perhaps below around 5 millimoles per litre after myocardial infarction.
I think we better move on. We'll come back to this discussion. I think this is a very important one. But Dr. Keach is going to talk now, and the title of his presentation is Usefulness and Limitations of Meta-Analysis in the Evaluation of Lipid-Lowering Drug Trials. Tony?
Thanks, Bill. The reason meta-analysis is important is because, as doctors, we're trying to determine public health policies and to determine whether treatments that are on offer are in fact effective, or whether in fact they offer no useful benefit. And often the sorts of effects we are looking for are really quite modest. For example, the sorts of benefits of treatment may be less than 20% reductions in a particular form of clinical event, or even perhaps less than a 10% reduction in mortality. But that might still be really very worthwhile, particularly in conditions that are very common. So often we're looking to differentiate between no effect of a treatment and a very modest effect in a common condition, such as myocardial infarction, coronary events, and the like. So, unfortunately, as you've seen from Professor Ferulio's presentation, often the trials are just too small to reliably determine whether the benefits we're looking for exist. And unless there are larger trials, sometimes we resort to meta-analysis, which is a means of statistically formally combining the results of the individual trials to gain greater power. And on this first slide, you can see that for a hypothetical trial that reduces a particular event 20%, when the size of the trial is small, here for example 200 patients, then the confidence intervals for the 20% estimated reduction are really very wide and do not reach statistical significance. And in fact there could be an 80% reduction in such a study, or there could be a 50% increase, adverse effect of treatment. However, as the trial size increases from 200 to 2,000 to 10,000 individuals, and the number of events increases from 8 versus 10 up to 400 versus 500, the statistical reliability of the same 20% estimate of benefit improves dramatically. And we can see here for the very large trial that we have a very tight confidence interval around the estimated benefit. And this allows us to reliably predict that treatment is effective and helps to predict the magnitude of that benefit that might be offered. And so meta-analysis has been particularly important, nowhere more so in the area of cholesterol trials, where there have been many, many small trials that have lasted over just a very short period of time. What it offers is a resolution sometimes of uncertainty about treatment, or sometimes where it is not able to do that, it can help us direct further research. However, it is labour-intensive to do well, and can never be better than the data that is available to put into such an analysis. So perhaps we could go on to the next slide and just look at how meta-analysis has been used in the area of cholesterol. What I'd like to start with, in fact, is the epidemiological data. Meta-analysis is not only used to collate trial evidence, but also has been used to collate epidemiological information, observational evidence. And this is much more difficult to do reliably. And of course, cancer and cholesterol is a particularly contentious area. Here you see the recent publication in Circulation of the pooled epidemiological data, the collected data of epidemiological studies in both men and women looking at how cancer relates to cholesterol. And you can see that for both men and women, at the bottom end of the Western range of cholesterol, there appears to be an increased incidence of cancer associated with a low level of cholesterol. Now, the problem with this sort of information is that cholesterol correlates with many, many other factors, such as social class, education level, marital status, alcohol, smoking, and the like. And unfortunately, the epidemiology has not been able to sort this out for us. And at present, it doesn't tell us whether the cancer lowers the cholesterol or, in fact, the cholesterol is causing the cancer. So it hasn't really, I don't believe, told us that low cholesterol or lowering cholesterol causes cancer. And to reliably determine that, we need to look at the randomized trials where things such as social class and other confounding factors are randomized and hopefully evenly balanced between groups. When we look at the trials, in fact, there have been a number of meta-analyses performed to date, and I'm sure most of you are familiar with them. Part of the problem, however, is that the data must be compiled in a very careful fashion, and one must be very systematic so as not to put undue emphasis on trials which are published, for example, compared to trials which, because they might be negative and not published, one has to gather all published and unpublished studies. Similarly, the studies must be randomized. The evidence must compare just cholesterol lowering with no cholesterol lowering, uncomplicated by other treatments that are given to one group and not the other. And the analyses must be by intention to treat methods. In other words, all the randomized patients must be followed up, irrespective of how much therapy or whether or not they received therapy. And what I'm showing you now is something that you may be familiar with already. It is the Oxford meta-analysis led by Richard Peter and my other colleagues. And what this shows is that although the old trials, as Professor Ferrulio said, have been plagued by very small reductions in cholesterol available, you can see that even with small reductions in cholesterol of less than 10%, there is an 8% reduction in coronary heart disease incidence over an average of 4 years duration. And what you can also see is that there's a dose response. With the trials that achieve greater reductions in cholesterol of 10 to 15%, you can see roughly a doubling in the reduction of coronary heart disease events. Now, we can also see that the dose response relates not just to the amount of cholesterol reduction, but the duration over which it ensues. And here you see the same information in 22 trials in 42,000 individuals, split by the trial duration. Trials of less than 5 years here on the left, and trials of greater than 5, between 5 and 7 years on the right. And again you see that the shorter duration trials achieved far less in the way of coronary heart disease reduction than the larger trials, 9% reduction compared to 22% reduction. And of course this is highly statistically significant, this large reduction here in the longer trials, as is the reduction of 19% in the trials that reduce cholesterol by more than 10%. So we have good evidence, as Professor Ferrulio said, of benefits on coronary events with cholesterol reduction, and greater benefits as the reduction becomes larger and the treatment duration increases. Now, as you know, the controversy largely surrounds the causes of death other than for coronary heart disease. And here you see the typical odds ratio presentation with a vertical line representing an odds ratio of 1, in other words, no difference between treatment and no treatment, treatment being no better or worse than no treatment to lower cholesterol, and to the left of the line, treatment being better than no treatment, and to the right of the line, treatment being worse than no treatment to lower cholesterol. And on the left are listed the causes of death: coronary heart disease, other vascular disease, accidental and violent death, cancer death, and others. And what you see is what you already know, the very definite reductions of 9%, highly statistically significant in coronary heart disease mortality, when cholesterol is lowered only an average of 10%. And what you see again is all the other causes of death appear to lie to the wrong side of the line. In other words, there is a suggestion that cholesterol lowering, when one looks at all the available evidence, has a mild hazard perhaps on other vascular causes of death, accidental and violent death, on cancer death, and on other deaths. But in no case do the confidence intervals not overlap the null hypothesis. So in no case, when one compiles all the evidence that's available to date, is there good evidence or definite evidence that lowering cholesterol has an adverse effect on these conditions. So we're faced with a definite benefit on coronary mortality and no definite evidence of hazard at present. Now, if one then looks at the sum total, you can see that the trend for total mortality is favorable, a 4% reduction in total mortality, but that this does not yet reach statistical significance, 4% plus or minus 3%, 2p equals 0.1. So, as Professor Ferrulio said, we have no definite evidence yet that total mortality is reduced. But that's not saying the same thing as we know total mortality is not reduced. I think we do not know that yet. And unfortunately, we require larger trials with big cholesterol reductions and many more patients and many more events to resolve the uncertainty about total cholesterol. Thanks very much. Sorry, total mortality. Thank you very much.
Thank you, Tony. Very good. Could I ask you, why do these trials have to be evaluated to be meaningful by the intention to treat method? For example, the lipid research clinic study, the Helsinki heart study, as I understand it, about 25% of those people quit taking the drug within 1 year of its beginning. And yet they stayed in the treatment arm, those patients, the entire period. Obviously, that prevented those reduction numbers from being as great as they were.
Well, I think it's a very important question. The reason is that one is trying to avoid bias. And the way one avoids bias in allocating patients to treatment A or treatment B in a trial is to randomize them. And when you randomize the patients, you achieve a balance, other than by the play of chance, in all the other factors that you can measure and other factors that you may not be able to measure or have not measured, such as social class, education status, and so on, and other blood factors that haven't been measured. Now, when you conduct an intention to treat analysis by the randomization process, of necessity those things remain balanced, and the difference between the treatment groups relates just to a policy to lower cholesterol, for example, in this case, or a policy not to do so. And it is reliable in that sense. Once you exclude patients after randomization for whatever reason, then you open the trial to bias, and you also provide an opportunity for medical practitioners, often unwittingly, to exclude patients because of particular conditions or because of a knowledge or a belief that perhaps some other sort of therapy might benefit the patient. So it's absolutely critical. And what you may have noticed is that just on December the 5th in the Lancet of 1992, the WHO clofibrate study has published an intention to treat analysis of that study that finished back in 1978. And that will be very useful to people who wish to include that information in meta-analyses in the same way as other information from other studies in an unbiased fashion. Does that answer the question?
Well, it does and it doesn't. In the lipid research clinic study, for example, it's my understanding that if you looked at the people who actually took 24 grams of cholestyramine for the 7-year period, there was a 25% reduction in heart attack, and a 25% reduction in total cholesterol and a 50% reduction in heart attack, not a 19% that produced this 2-to-1 principle.
Well, that is a subgroup, of course, of the patients who are randomized to receive the drug. I think one has to be very careful. I think the lipid research clinic study proved how careful one has to be about selecting a proportion of the patients who are randomized to a particular treatment group. Because you might remember that at one stage it was thought that when they looked at compliance in that study, they showed that the benefits were much greater in people who took the drug and had a larger reduction in cholesterol. But also when you looked at compliance in the placebo group, patients who complied with the placebo medication had a much better outcome than patients in the placebo group who did not take their medication. And it shows that there's something about whether one complies with treatment that is closely related to clinical outcome. And that's not surprising, of course. So I think one has to be very, very cautious about exclusions after randomization. And the best way to secure against that sort of bias, a very substantial bias in that particular study that would have arisen, is to perform an intention to treat analysis.
Well, I'm afraid we better move on here. Dr. Gilbert Thompson is going to be the next presenter. The topic, safety and efficacy of cholesterol-lowering drugs. Gil?
Thank you. Good afternoon. I'd like to start by comparing the efficacy of the lipid-lowering drugs which are in common use in Europe at the present time. Cholestyramine used to be perhaps the best way of lowering LDL cholesterol, and you can see that a dose of 24 grams a day will result in approximately 23% reduction in LDL cholesterol, but unfortunately there's an undesirable increase in triglyceride. Nowadays, the most effective LDL-lowering drugs are the statins, and I've shown here the effects of 40 milligrams of simvastatin, a 44% reduction in LDL cholesterol, and similar reductions can be achieved by other members of this class of drugs, notably lovastatin and pravastatin. there's also a slight increase in HDL cholesterol and a slight decrease in triglyceride, both of which are desirable. Nicotinic acid in doses of 4 grams a day is a highly effective means of increasing HDL cholesterol and pretty good also at reducing triglycerides. However, there are undesirable side effects of this drug, which is not easy to take, and it's not a particularly effective reducer of LDL cholesterol. Gemfibrozil is one of the fibrates. This is better than nicotinic acid at reducing LDL cholesterol. It's not so effective in increasing HDL cholesterol, but it's more effective than the statins in this respect, and it is the most effective of the drugs in terms of reducing triglyceride. Finally, Probucol. This is a slightly unusual drug in that, if anything, it tends to have rather disappointing or even adverse effects, theoretically speaking, on serum lipids. It's relatively ineffective at reducing LDL cholesterol. It's highly effective at reducing HDL cholesterol, which might be thought undesirable, and it has really no effect on triglycerides. But it is possible that Probucol is interesting and useful, perhaps because of its antioxidant properties. Now, as far as side effects go, the anion exchange resins are not easy to take. They cause gastrointestinal dysfunction in a high proportion of patients, and this leads to poor compliance. The HMG co-reductase inhibitors are much easier to take, but they can in some instances give rise to reversible abnormalities of liver function and also rarely to a clinical myositis. The fibrates, they also can sometimes cause myositis, particularly in patients with abnormal renal function, and they do also have this tendency to increase the lithogenicity of bile and thereby predispose to gallstones. As far as nicotinic acid goes, as I said, both it and its analogues do tend to be difficult to take. They cause gastrointestinal upset, they can cause hepatic dysfunction, they cause cutaneous flushing, and also they can induce hyperuricemia, so you wouldn't wish to use these drugs in patients with a history of gout. And finally, Probucol. It tends to cause diarrhea in some patients. It can cause prolongation of the QT interval on the electrocardiogram, and as I mentioned earlier, it has this theoretically undesirable effect of lowering HDL cholesterol. Now, I'd like to speak a bit more about the HMG co-reductase inhibitors because they're the newest and most potent of the lipid-lowering drugs available to us. These drugs act by competitively inhibiting the action of this key enzyme on the cholesterol synthesis pathway. They prevent or reduce the rate of conversion of HMG-CoA to mevalonic acid and thereby decrease the rate of formation of cholesterol. This slide shows the effects of one member of this class of drugs, namely lovastatin, and you can see that it is highly effective in reducing cholesterol both in patients with familial hypercholesterolemia and also in patients with non-familial hypercholesterolemia. This effect is dose-related, so there's a greater reduction with 40 milligrams twice a day than with 20 milligrams once a day. Now, the effectiveness of the HMG co-reductase inhibitors can be even greater when they're used in combination with an anion exchange resin. And this combination is particularly useful in patients with severe hypercholesterolemia, especially those with familial hypercholesterolemia. And you can see here how a combination of simvastatin and cholestyramine in these 12 patients, Dutch patients with familial hypercholesterolemia, resulted in a better than 50% reduction in LDL cholesterol. As far as adverse experiences, these was carefully studied in the EXCEL study, a one-year follow-up of 8,000 patients who were allocated either to placebo or to various doses of lovastatin. As far as abnormal liver function tests were concerned, there was no increase in the frequency of abnormal liver function tests at the low dose of lovastatin, but there was a significant increase in those given the highest dose of lovastatin, although again this only occurred in 6% of patients and was virtually always reversible on withdrawal of the drug. Myositis, defined as muscle pain and a CPK 10 times greater than the upper limit of normal, did not occur at the lowest dose of lovastatin and only occurred in 0.2% of patients on the highest dose of 80 milligrams daily. And as far as ophthalmological adverse effects were concerned, there was originally anxiety about the possible cataract-inducing properties of these drugs, but you can see from these data here that there was absolutely no significant difference between the placebo nor the lovastatin treated, and I think we can dismiss this as a serious probability. As far as the myositis goes, as I mentioned earlier, this is pretty rare when lovastatin is given on its own, but the frequency is much greater when this drug is combined with some other drugs, particularly cyclosporin. And in this particular study, you can see that a frequency of myositis of less than 0.2% when lovastatin was given on its own was increased to almost 30% when the drug was given in combination with gemfibrozil and cyclosporin. So one has to be very careful when you're using this particular combination. Finally, just to return perhaps to the theme which Professor Ferulio also mentioned earlier, the efficacy of these drugs in terms of their impact on coronary atherosclerosis. During the past 8 years, there have been 7 randomized regression studies published. The most recent one, the St. Thomas's Hospital atherosclerosis regression study, was a British one, but all the other ones took place in the United States. If we consider the effects purely of those trials which involve drugs, that's to say the type 2 intervention trial which used cholestyramine, the CLASS trial which used cholestyramine and nicotinic acid in combination, the FATS trial which used either cholestyramine and nicotinic acid or cholestyramine and lovastatin, the San Francisco SCORE trial which used triple drug therapy of lovastatin, cholestyramine and nicotinic acid, and the STARS trial, which used cholestyramine alone, you can see that if one averages the effects of these trials, on average, the treatment group showed a 29% greater reduction in LDL cholesterol than the controls and a 19% greater increase than HDL cholesterol in the controls. These changes in these 2 key lipids were accompanied by 23% fewer patients showing evidence of progression of their coronary disease in the treatment group, and 16% more patients showing evidence of regression. So overall, almost 40% of the patients in the treatment groups in these trials showed either arrest of progression or regression of coronary disease when they were treated with a combination of diet and effective lipid-lowering drug therapy. So I think this is very strong evidence of the desirability and potential benefit of treating hyperlipidemia in patients with pre-existing coronary disease. Thanks.
Thank you, Gil. Comments? Which of these lipid-lowering drugs do you use the most?
Well, as I tried to indicate at the start, I think it depends very much on the type of hyperlipidemia that you're treating. But if, for example, we're talking about patients with familial hypercholesterolemia in whom the main problem is an increase in LDL cholesterol, then if they were resistant to diet, which they usually are, then I would put them probably onto an HMG-CoA reductase inhibitor initially, and simvastatin is probably the most potent of the 3 available in Europe. And if the simvastatin on its own was insufficiently powerful, then I would supplement it with an anion exchange resin such as cholestyramine or cholestyramine. On the other hand, if one was treating somebody with mixed hyperlipidemia, with a raised triglyceride, moderate elevation of LDL, and a decrease of HDL, I'd probably give them a fibrate to start with. And either bezafibrate or fenofibrate are both very good drugs, widely available in Europe.
Well, we'll be back on this discussion, but we better end this part.
Let me stop you there for just a few moments. We'll take a short break. I know that some of our sites like to collate their questions. We look forward to hearing from you. We'll leave you with a reminder of our fax and phone numbers. Join us yourselves in just a few moments. Thanks very much indeed. We just take a bit of music from there. Well, welcome back. Before we take our first question, let me remind you, if you're calling from a site equipped with an audio convener, to keep your button down when you're using the microphone and to release it when you're listening to the studio. I know it's a bit awkward, but it does cut out that echo or howl around, as it's known. Well, Dr. Roberts, I think we've got our first fax in from Hungary. I'll let you take it.
Okay.
It's an impossible name. I've done you a disservice there, but we apologize in advance for pronunciation.
Dr. Jargon, some guidelines have been proposed about the daily intake of cholesterol. There is also some data about the fact that eggs without saturated fat do not raise the cholesterol level. Are eggs still forbidden, or can hypercholesterolemic patients eat eggs without limitations? That question reminds me of Bill Castelli, who tells a story about the egg sucker from Chicago. And this man drilled a hole in eggs and sucked 35 eggs per day. And his cholesterol level was approximately 750 milligrams per deciliter. When he quit sucking these eggs, his cholesterol level fell to under 200. Do one of the panel members want to comment on this question?
Well, I might perhaps comment on it. I think there was a study published not so long ago by Gus Schoenfeld and colleagues from St. Louis, where they looked at the effect of 6 eggs a day on serum cholesterol in a group of individuals, given either with a normal diet or with a saturated fat-rich diet or with a polyunsaturated fat-rich diet. In all instances, the average level of cholesterol increased when the eggs were given, but it increased far more when they were given with saturated fat than when they were given with polyunsaturated fat. And there's one other factor that one has to take into account when trying to give advice, and that is that there seem to be some people who can eat as many eggs as they wish without raising their cholesterol, whereas there are others who, even if they take more than, say, 3 or 4 a week, will show a rise. So it very much depends upon who you are and what you eat your eggs with. But undoubtedly, the traditional English breakfast of bacon and eggs is a pretty hypercholesterolemic and atherogenic one.
But of those 2 items, it would be much better to eat the egg than to eat the 3 strips of bacon. Would you agree with that?
Yes, I think, you know, if we switch to eggs and kippers, that would be probably very healthy.
Yeah. In the U.S., most American adults take in about 500 milligrams of cholesterol each day. A toothpick weighs 100 milligrams. So in the U.S., most adults take in about 5 toothpick equivalents of cholesterol every day. Also, we take in about 140 grams of fat per day, and about a third of that is saturated. So the quantity of fat is enormously greater than the quantity of cholesterol, as we all know. There's a telephone call.
Okay, let's take Dr. Trimarco from Naples. Can you hear us in Naples?
Yes.
Could we have your question, please?
Can you discuss the role of the reduction in LDL cholesterol and that of an increase in HDL cholesterol in the prevention of coronary artery disease and also in the regression of the atherosclerotic plaque?
Did everyone hear that question? Gil, can you handle that one? Maybe you repeat the question.
Yes, I think the question was, what is the role of LDL reduction as opposed to HDL increase in the management of atherosclerosis, in particular with trying to induce regression? I think that the data that we have would suggest that each are equally important. In other words, that something like a 20% reduction in LDL cholesterol will achieve an equivalent benefit to a 20% increase in HDL cholesterol, and that the most marked benefits in the regression trials have been observed in those trials where combination drug therapy has been used, where LDL reduction and HDL increase both occurred simultaneously.
Giorgio, you want to add to that?
I have nothing to add. I just added the fact that we have also to consider, always to consider these 2 main factors that are playing. the LDL increase and the HDL decrease, so that the ratio, when it goes over 5%, becomes a real risk situation. If you add also, as I mentioned before, an increase in triglycerides, then, I mean, you cannot expect a regression, but a quick and fast evolution of atherosclerotic lesions.
What do you do about the patient who has a total cholesterol of 300 milligrams per deciliter and an HDL of 100 milligrams per deciliter? The ratio is very good. Gil?
I tend to pat them on the back and tell them that they will outlive me.
But their LDL cholesterol is quite high.
Well, I think you have to obviously not completely ignore a high LDL, but I think that if it is accompanied by a very high HDL, and 100 is very high, then the risks associated with any given of LDL cholesterol are much, much less than they would be if that HDL was normal or low. And I think that particularly if you have elderly women who've reached the age of 70 with a cholesterol of 300 and 100 of it is HDL, I would not personally embark on any radical therapy.
I think we better take the next question, Dr. Zanchetti from Milano.
Hello? Hello? I think we have two questions here from Milan. One is the high incidence of myositis observed when a statin is associated with cyclosporine, or only when there is a triple combination, statin, fibrate, and cyclosporine?
Dr. Thompson, you got at that one a bit in your presentation. You want to comment again on that?
I think that the highest incidence has been reported when you get that triple combination, triple therapy being used. But I still think that even if you're just giving a statin with cyclosporine and no other drug, you also get some increase. I think it is possible to achieve safely significant reductions in cholesterol using low-dose statin with cyclosporine, but I think you have to be very careful if you're going to contemplate using higher doses than the minimum.
Let me ask about reversibility of the myositis. It's my understanding that if the hepatic enzymes go up with, let's say, one of the statin drugs, that if you stop the drug, the enzyme comes back to normal, and it might be possible to start that same drug again and not get a rise the second time. But as far as I'm aware, there's never been any permanent hepatic damage as a result of therapy with lovastatin, simvastatin, or pravastatin. What about myositis? Once you get myositis, what happens?
I think it usually resolves when the drug is withdrawn. In my experience, it always resolves when the drug is withdrawn, although it can recur if the drug is reintroduced in some instances.
So with the statin drugs, there's no evidence of permanent damage?
Not to the best of my knowledge.
Okay, Bill, can we go back to Dr. Zanchetti? I think he has a second question for
Okay.
you. Dr. Zanchetti, your second question, please. Zanchetti, sorry. Dr. Zanchetti, are you still with us? Hello?
This one? Hello?
Do you have your second, could you have your second question, please?
Yes, yes. My second question is what to do with a coronary patient whose total cholesterol is normal, but HDL cholesterol is very low. Do you do anything, and which kind of drug if you give any drug?
Anyone?
Well, you will try, of course, to increase the HDL, especially with what we call the hygienic type of measures. I mean, encouraging him to do physical exercise. Of course, if he's obese, try to go down with weight. And if the total cholesterol is normal, and we have to, of course, agree what we mean by normal. If it's around 200 or below, I don't want to give him any drug, of course.
Let me ask you, assuming that a person has, let's say, a HDL level of 10 milligrams per deciliter, and that person does not smoke, does a lot of physical activity, is at ideal body weight, is there any drug really that'll raise that HDL level?
The fish oil, for instance. The fish oil, I mean,
I think it depends on the cause. I mean, I think that such a low HDL as that would almost certainly have a genetic basis, and there may well be a mutation of, for example, the ApoA1 gene that precludes the normal formation of HDL, and in that instance it's going to be very difficult to get it raised. On the other hand, I have, for example, got one patient who had an HDL of about 0.6 millimoles per liter to start with. He had his first coronary at the age of 38. And he, in fact, put himself on nicotinic acid after reading a book about cholesterol reduction. And he's not only managed to get his HDL up to within the normal range, but he has also managed to significantly reduce the level of Lp(a), another risk factor, which happened also to be raised in this particular instance. So I think it's always worth trying the effect of drugs such as nicotinic acid.
Gil, I'm a little concerned about targeting HDL for treatment when I'm not sure that we have definitive evidence that raising the HDL, given that we know that HDL is a risk factor inversely related to coronary disease, I'm not sure that we have the evidence that raising HDL, independent of what we're doing to total cholesterol or LDL cholesterol, is necessarily of therapeutic benefit. What do you think about the evidence?
Well, I think the evidence in man is largely epidemiological, and as you say, it's very difficult to dissect out the effects of diet or drugs on other lipoproteins that tend to sort of inversely vary with HDL. As Bill Roberts pointed out, very often a low HDL is associated with a high triglyceride, and if you manage to raise the HDL, it's very often at the expense or accompanied by a reduction in triglyceride, and it's hard to know which of the two is beneficial. But having said that, there are certainly animal data. Perhaps the most impressive was a study in transgenic mice who had the ApoA1 gene transduced, and these mice were protected to a large extent from experimental atherosclerosis in contrast with their non-transgenic cousins. So I think there are increasing data that HDL is important.
I want to move on, gentlemen. We've got some calls stacked up.
Okay, this is Dr. Sinvishi from Budapest.
I would like to ask you about the ill-famed paper in the British Medical Journal about the bias, the problem of the bias in the meta-analysis about the successful treatment of hypercholesterolemia. And I think that your discussion in your panel on the meta-analysis was a little bit oversimplified. I would like to hear the panel's or William Roberts' comment on that problem. Thank you.
Tony, you better take that. Can you repeat the question?
Well, I think the question is asking about meta-analysis in general and about the published meta-analyses of cholesterol-lowering trials. Would that be correct?
I would like to know about what's your comment on this British Medical Journal paper of Ravenscoe, who reanalyzed the meta-analysis, and he claims that the whole business is biased in favor of the success.
Okay. Well, I think my own personal views on that paper are written in a letter of response published in the British Medical Journal after that paper by Ravenscoe. I think his interpretation is not correct. I don't think the publication bias is related to whether trials were positive or not, but in fact relates to how likely the trials were to get a result. In other words, how powerful the trials were to test a cholesterol-lowering hypothesis, in fact. In other words, trials that didn't actually lower cholesterol, or for example may have lowered cholesterol less than 3%, haven't been given a lot of weight by physicians, naturally, as you'd expect, and particularly trials in very small numbers of patients. Whereas in contrast, trials that involve large numbers of patients over a long period of time with large cholesterol reductions have been given a much greater emphasis and certainly are referenced more widely in the literature. And in fact, if you make an analysis of Ravenscoe's data in the British Medical Journal, as was done by Professor Symes in Australia, but is as yet unpublished, you will find that his publication and reference rates depend on the power of the trials to look at cholesterol lowering rather than whether the trials results were positive or negative, in fact. I think, in more general terms, meta-analysis, as I said before, particularly in this area, has been complicated by the inclusion of non-randomized trials and non-intention to treat analyses, and sometimes multiple risk factor interventions where you cannot be sure whether any of the benefits or any of the hazards seen in the trials relate to cholesterol reduction rather to blood pressure treatment, smoking, weight reduction, and so on. Do you have some general comments as well?
No. I
Okay.
think
In that case, we'll go to Dr. Chiarello in Naples. Can you hear us in Naples?
Yeah, sure.
Can we have your question, please?
Okay, I would like to ask Dr. Bill Roberts if he can comment on what's the role of oxidized lipoproteins in promoting the formation of plaque. In other words, as far as atherosclerotic risk is concerned, is it more relevant the absolute level of LDL or the amount of modified?
Yeah. Well, the question has to do with the importance of oxidation of the LDL particle. The answer, I don't know for certain, but it appears to me from studies which have focused around probucol that this is a very important arena, and it looks like these antioxidants might be important and work in a very different way and a beneficial way from some of the lipid-lowering agents. I think it's a good area to keep an eye on. Either of you folks have any comments to add to that?
Well, certainly in experimental situations, the macrophage, which is the key cell in the atherosclerotic plaque, doesn't take up native LDL, it only takes up chemically modified, and one of the chemical modifications which seems to occur is oxidation. So I think it can be crucial. The only problem is that the only evidence so far of benefit from antioxidants has been in experimental animals, and we're still awaiting, as Bill Roberts indicated, such data in man.
Dr. Chiarello, are you happy with that answer? Are you still with us? Hello, Naples. Can you still with us? Yeah, okay. We'll move on to a fax from London.
Could I ask, what about the combination of an antioxidant with a HMG-CoA reductase inhibitor, because of the actions of each being very dissimilar?
Well, the net effect would be that the reduction in LDL cholesterol that you get with the statin, the HMG-CoA reductase inhibitor, would not be influenced either way by the probucol. But the probucol would decrease the HDL cholesterol, which would otherwise have been unchanged or raised by the HMG-CoA reductase inhibitor. And the only question which still remains to be resolved is that decrease in HDL induced by a drug adverse or not?
Can I add that probucol is not the only antioxidant that we're aware of. For example, the naturally occurring antioxidants may also be very important, such as vitamin E, and in work that we've done in Oxford, there appears to be no interference by vitamin E of the effect of the statins to lower cholesterol, and vice versa, simvastatin or the statins don't appear to interfere with the antioxidant capacity of something like vitamin E in terms of making LDL more resistant to chemically induced oxidative damage.
Do you take vitamin E, vitamin C?
Not on a regular basis, but I am involved in setting up a large trial to test whether lowering cholesterol and possibly making it less toxic, less oxidizable with an antioxidant might have added benefit.
Okay, we have a fax question. How would you compare what is happening in the treatment of hypercholesterolemia today with what happened in the 1970s with the treatment of hypertension? I've got a slide on that. The slide number is 507. This slide was produced in 19 1972 in the USA, and it showed the frequency of treatment of hypertension in the USA in 1972. And that is, if you took, for every 100 patients with hypertension, about 60 knew that they had it, and the other 40 did not know that they had it. Of the 60 who knew they had it, 30 were not receiving an antihypertensive drug, and 30 were. Now, of the 30 who were seeing a physician, only 15 were being adequately treated. So in 1972 in the USA, only 15 of every 100 people with systemic hypertension were being adequately treated. Today, that percent is above 50%. Now, if we substituted in this slide hypercholesterolemia for systemic hypertension, I would think rather than 15 out of 100 people being adequately treated, we would be less than 5% of the population being adequately treated. So the hypercholesterolemia pool is a bottomless pit at the moment, and I think the drugs should be used more often myself. The toxicity of these drugs is minimal compared to the toxicity of atherosclerosis. So I'm absolutely convinced with time these drugs will be used more just like the antihypertensive drugs have been.
Okay, we have a live call from Naples. Dr. Loeli, can you hear us?
Yes, my question is what is the best therapy to reduce hyperlipidemia in patients with glomerular nephropathy? If I have understood, in this case, the risk of myositis is bigger. Have I understood?
Yes. Can you repeat that question, Giorgio? Did you get that question?
Yes, well, the colleague is asking what should be done in patients with nephropathy, with kidney disease, high cholesterolemia, and what the type of, in which the statins should be used with caution, what to do. Apparently, I think...
Could I answer that, Bill?
Yes, sir.
I think it depends upon the type of glomerulonephritis that we're talking about. In some patients, the main change that will be observed will be hypertriglyceridemia, and I think there you probably can use a fibrate, but you should use it with caution and in low doses, because that is a situation where there is a risk of myositis with fibrate therapy. And perhaps the most appropriate fibrate to use is gemfibrozil, because it tends to be metabolized more by the liver than by the kidney. On the other hand, if you have a nephrotic syndrome where there's hypoalbuminemia and protein loss in the urine and a major increase in LDL cholesterol, then it's entirely appropriate and safe to use one of the HMG-CoA reductase inhibitors, because they're largely excreted via the liver, and there is no real increase in myositis in that particular situation. They're dangerous where there's liver dysfunction rather than renal dysfunction.
Question from London Fax. What, according to your opinion, is the reason for so much controversy surrounding cholesterol lowering? Well, that's an interesting question. I think